everyone. I am Dr. K. Priyanka, second year postgraduate in Government Medical College, Anantapur. Today my topic is a case series of ocular manifestations in pulmonary tuberculosis. Tuberculosis is a chronic infection caused by Mycobacterium tuberculosis that is characterized by formation of granulomas. Ocular manifestations are primary and secondary. Primary ocular tuberculosis, which is isolated ocular disease, and when eye is the initial port of entry of the bacilli. Secondary ocular tuberculosis is by hematogenous spread from primary sites such as lungs and lymph nodes. Prevalence is about 0.39% in South India and about 9.86 in North India. Aim of the study: to study ocular manifestations in patients diagnosed with primary tuberculosis in Government General Hospital, Ananthapuram. Objectives: to know various types of ocular manifestations in patients diagnosed with pulmonary tuberculosis. Materials and methods: it's an observational study with 10 patients. Period of the study is between December 2022 to May 2023. Place of the study is Government General Hospital, Anantapur. Inclusion criteria: patients consenting for research, tuberculosis positive patients, and patients with ocular complaints such as redness, watering, eye pain, and diminution of vision. HIV and HBsAg were negative in these patients, admitted in hospital as inpatient. Other tests were done to rule out other causes of granulomatous uveitis such as peripheral blood count, ESR, CRP, RA factor. Montauk's test, chest X-ray, and CT tests were done for confirmatory of pulmonary tuberculosis. Ophthalmic examination such as visual acuity testing, slit lamp examination, fundus examination, color vision testing, and IOP monitoring were done in these patients. Results: out of 10 patients who were diagnosed as active tuberculosis and who were on ATT with ophthalmic complaints, out of them 7 were males and 3 were females, showing male predominance with having a smoking history. 40% had granulomatous uveitis, 30% had flexural conjunctivitis, 20% had nodular scleritis, and 10% had diffuse choroiditis. Patients were started on oral and topical corticosteroids and cycloplegic eye drops along with ATT drugs. ATT, HRZD 2 months intensive phase and HR 4 months continuous phase. Discussion: clinical manifestations of ocular TB may have various forms, extraocular and intraocular. These are non-specific. Primary ocular tuberculosis refers to a focus illness, and secondary or endogenous ocular TB develops from a local injury through contagious spread or hematogenous dissemination. The conjunctiva and anterior segment of the eye are mostly affected by primary tuberculosis, leading to keratitis, scleritis, ulceration or flectanulosis on the cornea. Choroiditis is the most typical intraocular presentation in tuberculosis, followed by flectanular conjunctivitis, scleritis, keratitis, retinal vasculitis, vitritis, and posterior uveitis. Conclusion: most common spread is by hematogenous spread, and ocular TB can involve any part of the eye with or without systemic involvement. The gold standard procedure: presence of Mycobacterium tuberculosis in culture. PCR of ocular fluid is a recent alternative to cultures. Diagnosis in most of cases is presumed ocular TB. Ocular findings must be supported in context with history, chest X-ray, and tuberculin skin test. Negative tests do not rule out ocular TB. Treatment of ocular TB is the same as for pulmonary TB. Timely intervention, steroid therapy, and cycloplegic therapy is often required to prevent irreversible ocular damage. These are my references. Thank you.
Okay, thank you. So, when you said choroiditis, it's diffuse. What do you mean by that? What was the pattern of choroiditis?
In fundus examination, like fog in the light appearance, we could lightly make out.
No, as in choroiditis has different patterns. So, what was the morphological pattern that you observed to be common? When you what CT was done? Was it plain or HRCT?
No, HRCT were done for the patients.
For all.
Systemic.
So when you were going for HRCT, why chest X-ray?
It's a routine examination that has been done.
No, what is the sequence of investigations you follow usually?
Montauk's test, chest X-ray, and CT followed by CT.
No, I mean it will save up some money. Chest X-ray misses 40% of the lesions. So when you're going for it, you might as well directly go for HRCT.
Yes.
Yeah.
Thank you.
Okay, thank
Thank
you.
you.
So what was the MAN2 reading like in all these patients? Was any sputum tested or gene expert or something like that? Okay. Was there any drug resistance? Multi-drug resistant TB? All responded to treatment? All right, thank you.